Okay, so I'm going to talk today about the protocol that we used to guard the safety and privacy of minors enrolling in our digital cohort study that started back in 2017. Um, so we have a new version of the cohort now that is using a modified version of this that I'll kind of get to in the conclusions based on the data from this first study. But this was from what was called the Unite cohort, which was a cohort of 8,000 sexual minority men ages 16 and over across the United States that enrolled from 2017 to 2018. And then we followed them all for 3 years doing annual HIV testing and surveys. So this is not my MRP. I'm actually not presenting my MRP because it's already published and many years old. So I'm happy to share the paper with you, or it's probably on the website. So I'm presenting something a little bit more recent. So as was already discussed in detail yesterday and doesn't really need to be covered today, there are lots of issues with HIV preventive research with minors, including waivers of parental permission, reporting requirements, particularly around sexual behavior and the age of consent for sexual behavior within different states, and the types of data that you collect around sexual behavior. So we're very careful around when we collect ages of partners and things like that that might trigger mandated reporting, but also suicidality. I'm not going to talk about our suicidality protocol today, but I'm happy to share information about it if folks have questions. We do have a protocol for how we handle acute suicidality in these remote cohorts. Obviously can't directly intervene. There's lots of variability in state laws regarding consent to HIV and STI testing, as was also discussed yesterday. State laws are often a little ambiguous. They don't always directly say what minors can consent to. Sometimes it's prevention services. Sometimes they do specifically mention HIV testing or STI testing. Sometimes they mention HIV treatment. And so there's not 100% consistency, but for national studies, IRBs have typically allowed us to start at 16 because that is the age at which there is at least some ability for minors to consent to at least one of those areas of service in every state. Most of the states are younger than that, but some of the more conservative states do limit it only to 16 and older. So we then limit enrollment in these studies only to 16 and older as well. And then lots of practical issues regarding privacy of youth living with their caregivers, which most people under 18 are, and many people over 18 also are. And so that's what I'm going to focus on today. So this study has a waiver of parental permission. We don't do any reporting. We don't collect any data that requires mandated reporting, except for, a circumstance that, knock on wood, has never happened so far, where we would have to call 911 in a case of acute suicidality, but that's never had to happen so far. And in terms of variability in state laws, we go with the age of 16. So in terms of eligibility for the Unite cohort study, they had to be self-reported as HIV negative or unknown status, and then subsequently test negative for HIV at their baseline enrollment assessment. They had to identify as gay, bisexual, or queer, age 16 years of age or older. Also, they had to be male identified. So cis men and trans men were eligible for the study, but had to be male identified. Had to be able to receive mail within the United States, including the District of Columbia and Puerto Rico, reporting risk for HIV infection. So this was, like I said, back in 2017. And so the CDC still had guidelines on risk criteria for PrEP. And so we used a modified version of those criteria for enrollment. And in fact, they also could not be on PrEP and adherent to PrEP. So we enrolled people who were on PrEP but reported non-adherence. But if they reported excellent adherence, then we didn't enroll them in the study. And the study was available in both English and in Spanish. So all the folks under the age of 18 during the screener were provided with frequently asked questions document and a how-to technical guide. The how-to technical guide included things around how to ensure their privacy. So settings that they could change on their phones to ensure their own privacy and whatnot. The guides were written for young folks who were concerned about their privacy, but felt it could be managed if they were given the tools to increase their security. Potential participants were asked a series of questions designed to assess their capacity to understand, appreciate, reason with, and express a choice around participation in the specific protocol. And the young sexual minority participants were required to make and utilize a password to enter the Unite survey. So the way that it worked is people would get to the screener on one of the apps. So the most common app that people enrolled from was Grindr, but we also enrolled from Scruff and Jacked and social media as well. They would get the screener, which took about 5 minutes to complete and included a bunch of demographic behavioral questions. If they were under 18, the end of the screener then asked them the questions that I'm going to present to you today around privacy. And then based on their responses, they were either automatically cleared to proceed with enrollment, or we had sort of like an intervention that we would go through with them, a protocol that we would go through with them over the phone to discuss the issues of privacy before they enroll.
John, for the, when you're testing their consent understanding, is it an algorithm or how do you do that?
I'll show you.
Oh, okay. Great.
So as part of the screening process, the 16 to 17-year-olds answered a series of questions regarding their level of concern about and their perceived likelihood of potential breaches of privacy and confidentiality by parents or caregivers that they were living with at home. So this was done in 2 domains. We asked them about digital communications like emails and text messages, which we frequently send as part of these cohort studies. And we asked them about receiving packages because we have to send them HIV testing kits. And so they are receiving packages at home or at another location of their choosing. And so we asked about those 2 domains and how worried they were that their parents would intercept a digital communication, like reading their emails, or intercept a package and potentially open it. And then if they were worried about it, we asked them how likely it was that their parents would do that, right? So we started with worry because if their parents might do that, but their parents already know that they're gay or bisexual or queer, and they already know that they're sexually active, like the minor may not actually care if their parents intercepted a message or an HIV testing kit. And so we started with worry. And then if they were at all worried about it, then we asked about the likelihood that that might happen. And then I'll go into the procedures that we followed if they expressed both worry and likelihood about either of those domains. The important thing is that we never made the decision for them. We would, once we got them on the phone, go through all these issues with them and make a recommendation to them, but they were ultimately the ones to decide whether to join the study or not. So we might recommend that they not join the study. They could still decide to join the study, or we might recommend that it's fine for them to join the study and they could decide not to join the study. All right, so this is the main data. We screened 715 HIV negative young sexual minority men who were eligible for the study and aged 16 to 17. And on the left are the questions around concern around texts or emails. And on the right are the questions around concern around packages. So the question would be something like, how concerned are you that a parent or someone else you live with might read your text messages or emails? And how concerned are you that a parent or someone else that you live with might open a package addressed to you that was received where you live? So 67% of those we surveyed were somewhat or very worried. So a third were not worried at all that their parents, about what might happen if their parents were to read a text message or an email from us. So it's not worry that they would read it, it's worried about what might happen if they read it. And then the same thing for packages, about 71%, so about 1/5 were not worried about what might happen if their parent were to open a package from us that was sent to them. And so this was all very specific to this study, right? So this is not like, might your parent open an Amazon package? This is like, what if your parent opens a package from us? Of those who expressed worry, then we asked about the likelihood. So among the 2/3 that were worried about texts or emails, 40%, so a little less than half, said that it was actually likely that their parents would be able to intercept a text message or an email. So not surprisingly, youth these days are very tech savvy. Not a ton of them were worried that it would be likely. Well, actually, I mean, 40% is a lot, but it's not as much as the packages. A good number felt confident that they had privacy in their digital communications, which, by the way, is not super surprising given that we recruited them from Grindr. You're not allowed to use Grindr under the age of 18, and they're using it on the phones. So it's actually kind of surprising that 40% were worried that their parents are likely to intercept digital communications, given that they are probably on Grindr. So of the greater number that were worried about what might happen if their parents opened a package from us, which would have an HIV test kit in it, a lot more of them thought that that was actually likely. We didn't ask about whether that was like intentional versus accidental, like the parents might just like open all the packages that come to the house and distribute the things to all the people, or intentionally like surveilling packages that come to them. We didn't get into that, but the vast majority were concerned that it would be likely that their parents would open a package that we sent them. Folks were given the option of having the package sent to another location that felt safer to them. And during the call that we did with them after this, they were given the option of having it sent to another location, which could be like a friend's house where they felt more safe about their friend's parents not disclosing that information. It could be a school or like a community center or something like that. So 191 were flagged for texts or emails, 370 were flagged for packages. We then proceeded to collect contact information for folks, and not surprisingly, not all of these people gave us contact information. So we ended up with 237 total who were flagged for one or the other or both. And we proceeded to try to implement the protocol, which was to give them a phone call, which turned out to be a big mistake.
Oh, yeah. So who did you train to do the phone calls, and how did that?
We mostly had master's level clinicians or doctoral students in clinical psychology doing the phone calls for this study. We don't use clinical staff anymore for the current study, but at the time we were having these calls done by trained clinicians because it was the first time we had ever done it. So 237 were flagged. I'm sorry.
Those same like safety questions, did you ask to the whole cohort?
We did not. We are now asking those. Yeah.
The 18-year-old.
So we're now asking them of the entire cohort. We're not flagging people for this protocol to check on their safety. We're leaving it up to them to decide if they're over 18, but we are now asking during the screener of everybody because of the potential of like partners also like intercepting these things and then like questioning why are you in an HIV prevention study. So we are doing that now, but we didn't do it for this study. So big surprise, spoiler alert, we didn't reach almost any of these people and they did not enroll in the study. So about 3/4, we could not get them on the phone to go through the protocol. And so we were never able to assess the safety of joining the study. So they were never cleared to proceed with consent and enrollment. We did reach 47 of them out of 237. So 1/5 of them we reached, and we actually cleared them and they decided to join the study. So 1/5 of the people that were flagged who actually left contact information, we went through the protocol, which included the questions that I mentioned before here. So it asked about how likely they felt that the safety could be managed and the consequences. So we asked them to like imagine what might happen if their parent were to intercept a text message, email, or package, and to describe like what the consequences of that might be to better understand safety concerns. So is it just that they might be outed, but that they think their parents already know, and so like that wouldn't be as big of a concern for them, or do they think that there's a threat that there could be violence or that they might be kicked out of the house or any of those kinds of things, in which case obviously we felt much more concerned and suggested that they probably not join the study because we had to send them emails and text messages, right? That wasn't something that was avoidable in this protocol. So they knew that they were going to receive digital communication. So if there was any likelihood that their parents were going to intercept those and there could be violence or other harmful effects of that, we recommend that they not join the study because they were absolutely going to get emails and text messages from us. We reached 5 participants who went through the protocol and asked that their package be sent to a different address, but they never provided us information on that address. One participant went through the protocol and indicated major concerns about privacy and withdrew his participation for fear of being kicked out of his house if his parents were to intercept any of these things. And then 15 participants, upon receiving the call, said that they weren't interested in participating. So these were all the people that we reached. And then the majority of people we just never reached at all. So this is just the information of the people that we reached, one quarter that we reached.
Did you anticipate that there'd be a higher percentage of participants that went through the protocol? Like you got.
Yes, we anticipated we would reach more people, perhaps naively. But did not.
You would keep with this, anticipate that percentage again? Like we did this again, you get about 20% that are gonna do the protocol.
You know, it's really surprising because there are actually studies like this where they require a FaceTime to enroll minors, both to confirm that they are unique and valid, like people, fake participants, and to verify age and whatnot. So they like require an ID and everything like that. We at one point considered doing like an ID verification and then decided like that was not worth the hassle, because there are so many youth who don't have IDs that would be able to be validated, and B, there are lots of IDs that can't be validated, and there are people in this study that are undocumented and wouldn't have IDs to begin with. So we decided not to do ID verification, and definitely never even considered doing FaceTimes because of the volume of participants we were trying to enroll, 8,000 people. We screened 120,000 people for this study, and had more than 30,000 who were eligible and more than 20,000 who left contact information, who we then like pushed into the enrollment process for the study. So we obviously were not planning to do any FaceTimes with people. There are a lot of studies that do that. So we felt like the phone call was a lower bar and that we would eventually reach people, which did not happen. But we also found some differences in terms of the responses to the questions. So Latinx and bisexual young sexual minority men were more likely to express concern about male compared to their counterparts. Among those who expressed concern, Latino youth were also, Latino youth and those who lived in the Midwest and the West were more likely to report that this was likely for their parents to do. So these are, each of these issues around packages are more concerning for Latino youth and also for folks that live in the West and the
Ken,
Midwest.
did you know, did you ask if they have mobile phones?
They all had mobile phones.
So it's really weird, I mean, because it's weird that they would think their parents would read their mobile phone, because I'm just saying that, you know, some of the people we interviewed, they said they weren't concerned because they just erase it. Emails, I'm just, you know, it just.
Well, there are
it's
all
just
kinds of apps
interesting.
for parents to track what happens on their minors.
I see, I see,
Or like notifications that come up
Yeah.
and you're sitting by them.
I see, so
In
that.
fact, like
yeah, I see.
Apple makes it very easy now when you have a family set up on your phones to be able to read your children's messages.
Got it, I
So
get
it is actually not that. In fact, something like Grindr might actually be safer for them because it's not an app that they can monitor as
I
easily.
see, oh, I didn't. know.
Text messages and emails are a lot easier
Wow.
to monitor. And then we also saw so that was for packages, Latino youth felt like we're more concerned and felt like it was more likely. And then the same thing for packages, Latino youth and those who lived in the West were more likely to express concern about what might happen if their parents were to open a text message or an email. But we didn't see any differences in terms of likelihood of that happening. So
One question, where did you send those who were afraid? Did you send packages somewhere else ever?
we did not have any minors who were flagged for safety that we then sent a package to another location. We did have people that requested alternate locations that weren't part of this, like, that wasn't about a safety concern.
Right, right.
Yeah.
And is a drugstore a possibility or that would not work?
No,
No? Okay.
it would have to be somewhere, a private location, where someone would be willing to receive the package on their behalf. So like, it could be like a community center, if they had like a program staff member there who was willing to have the package sent to them on their behalf. So we would navigate that by phone with them. But again, like all this necessitated phone calls, which were nearly impossible to
Yeah,
do with these
exactly.
minors.
Yeah.
You only did HIV testing. There wasn't PrEP. You weren't giving out
At
PrEP.
baseline, we did HIV testing, and for half the sample, we also did rectal STI testing.
Yeah.
Which was not part of the rest of the study and was only done for half at baseline. Just to understand like the baseline prevalence of rectal STIs. Given its strong association with HIV infection.
PrEP.
No, there's no intervention as part of this study, other than giving them their HIV
It's
results.
also in a lot of states, minors can get HIV tested, but they can't get treatment. And they can't get PrEP. It's just very, right? It's very weird. Yeah, without parental consent, without parental consent, yeah.
So the conclusions are that the majority actually do report the potential for privacy related issues in a study like this. So like remote research with minors is challenging given the privacy landscape for them. Well-planned strategies can mitigate these risks to ensure safety. So we didn't have any safety issues, but as a result, we also couldn't enroll most of the minors who were screened eligible for the study. So we had a much lower representation of folks under the age of 18 because of how stringent these safety protocols were. So our recommendation, which we are now taking, is that alternate age appropriate means of contact should be considered. And that rigorous protocols for ensuring safety and privacy were successful, but also substantially limited the number of youth that were able to enroll. And so limit access into remote HIV research. So now our protocol, you asked, Celia, you asked about the algorithm. So it wasn't an algorithm for this because it was very straightforward. If they said there was any concern and any likelihood, then they were flagged for follow-up. We do now have a more sophisticated set of questions. So they answer those same questions, but then we have a series of open-ended questions as well, so that we can automatically clear people based on their responses rather than needing to call them. So they respond to those questions, and if it's clear from their responses to the questions that they submit that there aren't safety concerns, we let them know that we think it's safe for them to enroll, that it's up to them, and we send them the link that they can begin the enrollment process. And it has significantly reduced the number of people that we have to call, and we do also have built into the protocol the option of text messaging them, but we don't text message the ones who are worried that their parents might intercept their text messages. So just because the number of youth who are worried about packages was greater, that helps us with those whose main concern is packages. But for the ones that are concerned that their parents are reading their text messages, we don't text them to see if it's safe for them to join us.
I'm curious because this sort of seems, it's related to our discussion yesterday. But in some ways, you're proving that giving clear information about the risk and benefit did result in a higher percentage of dropout, right? And so it's interesting, and I'm glad that you're adding it to a larger age group, because I think it might be interesting, even though you're not creating the protocols for it, it could be interesting to see if you were to do that during enrollment with everyone, does that change sort of the proportion of people that retain? Because we're talking about, are people really listening to what the risks are when you're doing it?
Yeah, I mean, the one thing I want to just make sure is clear though, is that this was before consent. So they actually hadn't had the full detail about the study because
But even
once they're cleared, we send them the video that shows them like all the details about it. But yes, exactly.
But you're talking about a risk.
Yeah, you're talking
At
about
this point, and are they hearing it and are they understanding the impact of the risk in their lives? And I think the answer is yes, based on what you
Yeah,
said.
one of the things we do and in the screener is give them instructions on how to protect their confidentiality, right? But I think it's interesting that we might even put in a sense, if you don't think you can do this, then don't, but we talk about, making sure you're in a private room, if it's on the way, delete this, but the other thing I remember is, I think Alexis, so when she comes, she had everything on a website that would only appear when they gave their responses or whatever, and then it would not
Yeah, so
stay.
the minors in this study had a password protected landing page to go to get anything related to the study. So
And would
for the
people
rest of the,
access that?
Once they were in, you mean?
yes, correct. So once they were cleared to enroll in the study, the first step was to create a password.
Right.
That
But
we
the
gave them
parents
like
access that-
guidance around like how to,
Parents access that website? Probably not, right?
not without the password,
Not without the password, right,
which
okay.
we instructed them not to save on their
Right.
phone in a place where their parents might be able to access it.
Mhm.
And we only did that for the minors at enrollment for this study, but we now use a landing page for everyone because it's just so much easier than sending a million emails. Like, because people would email back and be like, this link isn't working. Where's my link? And because they were reading like an email from last year. And so like we now just put all of that onto a website that they have access to via login.
And this has been a problem also in terms of dissemination when you're doing these survey studies. You know, because you don't want to email them with the results of the study or text them with the results of the study. I mean, that's a challenge that, you know, we've experienced. So we have a website where we post our results. It's a year later, so, you know, or 2 years later, and, you know,
Months to
I'm sure
go.
they're not checking. So anyhow, this whole thing about privacy, even for adults, is a big issue when it comes to our responsibility to, what I meant was to debrief, you know, you can't really provide them with the results of the study.
With your new protocol that has the open text,
Mhm.
so that you can clear some people and not need that, does that require a human to read the text, or is it somehow automated looking for keywords or something?
No,
It requires a research.
Our staff review it.
Okay.
So you were enrolling 2017 through
2018.
18, and then now you have a different.
Yes, so we started enrolling last October and are still actively enrolling.
Okay, and I was just wondering, given the political climate of parents being very concerned about their children's, you know, I think back then there was a little less like, it's my kid, I control what they learn, what they do, like the tension. Have you seen any increases in concern or like parents paying attention a bit more in the Southwest? Differences?
That's a good question. We haven't looked at that, but certainly can. I think it would probably be in both directions though, because I think there are a lot of parents who are taking the political climate very seriously and have become much more affirming as well, right? Like there's a lot less middle of the road at this
Yeah.
point. Like people are either very affirming or they're very unaffirming of their LGBTQ
Mhm.
youth. So I think we would probably see more parents who would also be like, "Oh, I'm so happy you're in this study." Whereas like before it would be like, why are you in this study? Like, I know you're gay, I'm cool with that, but like, what is this? And I think now we would probably see more that would be excited that their minors were engaged in research. The current study is also, so this one was really focused on individual level stigma and syndemics and how that influenced HIV outcomes. We found that the rates of HIV infection, not surprisingly, were
Took that choice away from
3 to 4 times as high for Black men in the study relative to white men. And that other factors that were strongly associated were a history of incarceration and meth use. So like stigma and syndemics were associated, but like the defining features of people that got HIV during the course of the study were that they were Black or Latino or multiracial, that they were meth users or had a history of incarceration. So the new study is all focused on structural stigma. So we're creating new metrics of state level LGBTQ stigma and state level structural racism, and looking at how that influences the HIV inequity. We're only enrolling folks that are Black, Latino, or multiracial in the new cohort, so there are no white participants. But we've also expanded the gender and sexual identity of the sample. So now we're enrolling trans and non-binary folks of any birth sex, as long as they have sex with men. And actually cis women who are LGBTQ identified, so like bi or lesbian identified cis women who report sex with a man are also eligible for the study. It's not the target demographic of the study, but they are also, we're being very broad with our sexual and gender identity criteria and much more restrictive of the race and ethnicity related criteria, given what we found in the cohort.
You know, I just want to say something interesting about, you know, lesbian, bisexual women who have sex with men. Our experience when we did studies with them is they have more health care because they go to gynecologists once a year. It's so just to point that out, we were really surprised, you know.
But keep in mind that these are women of color.
Yeah,
Right,
no,
I mean,
we did the study on black with
Okay.
black, very long title, but black, lesbian, and bisexual women who have sex with men. And, you know, they do see a doctor because they're women. And, you know, so it's very interesting. I just wanted to point that out that, yeah. So this is going to be very short for me. Okay, so what are, so basically this, I'm not really going to be talking about survey studies. I want to talk about when you're interview studies, for example, or some survey studies, but where you have information about people, but more not survey studies. Okay, so what are some of the participant vulnerabilities that might require you're thinking about disclosing information? So they could be at risk or living with HIV, and there might be a risk factor there, or at risk or SUD. I mean, one case we had once quite a while ago was, you know, finding out that, well, I'll have that, but just, you know, somebody was using a medication, I'm sorry, an illegal drug that had just been known to be incredibly toxic and lethal. And you're interviewing somebody and you find out they're using that drug. What are you supposed, they're a minor, what are you supposed to do? So, yeah.
Different if they're a minor versus an adult, do you think?
I think an adult, you tell them, but a minor, you wonder what your responsibility is. You know, that's the thing, because that's
No, I didn't
Yeah,
know.
no. Who are you going to tell for an adult? For an adult, I think you would tell them and let them know. For an adolescent, you could tell them, but the issue really is you have a responsibility to their parents, too, because their parents are the ones who see them every day. We see them, even if you're a clinician. You know, I do a lot of ethics work with psychologists or clinicians. You see them once a week. You know, that's not gonna protect them. So anyhow, it becomes an ethical issue in terms of what is our responsibility to a minor who may be high in risk taking, may not really understand the consequences of whatever a lethal thing means. So anyhow, it's just something we have to grapple with. They could have a comorbid mental health disorders, illegal behaviors that they're conducting. Obviously, we're working with people who are in desperate. Many of the people, I'm sure some of you work with, do not have homes, and they're subject to social stigma. So these are all the challenges that we're facing. When we're interviewing people, we may be talking about drug histories that trigger cravings. What do we do? You know, same thing, psychosocial histories may trigger PTSD if they had abuse or something else in their history. If we're talking about suicidal ideation, like David was talking about studies, but there's no post-experimental follow-up. You know, this could be, in my experience sometimes, because I work more with adolescents, I'm the first person they ever told. And that's scary. When I'm not a clinician, I don't have resources to do something, so I have to think about what's my responsibility to do. Or if we also did, you know, a geriatric study with the same thing. What happened? One of the people that we were interviewing had suicidal ideation. But in that study, we had been anticipating it, so we were actually doing the study in a physician's office. And so we asked the person, do you mind, can we bring you over to the physician to talk to you more about this? Because we weren't clinicians to be able to follow up on the suicidal risk. We can find out about domestic violence or retribution, that somebody is going to go out and actually kill somebody or kill somebody, which brings in, you all know the Tarasoff law. Everybody familiar with Tarasoff? Because you're not clinicians. So the Tarasoff law in many states is adopted for clinicians, which is that if you have a patient who says that they're going to seriously harm somebody, you can identify that person and you have the ability to estimate a high level of risk that they're actually going to do it. You're legally responsible to do something that ends up in warning that third party. So that can be through a police, informing the police or something else, or calling that party. But anyhow, it's never been used for research, but like Paul Applebaum, there has been arguments made that especially for people who are, and I just gave a talk to something at NIH that does violence, but researchers who specialize in violence have all those Tarasoff criteria. They're probably better than clinicians in estimating the risk of whether or not somebody is going to commit violence. They're interviewing people on violence, because especially now with guns, and the person may tell them about it. So anyhow, these are things that we encounter. The other part of it is, this is what always bothered me working with adolescents, that if they, and so I started doing a lot of research on adolescents' attitudes toward confidentiality and disclosure and what they wanted us to disclose. Because I was really upset, really personally, when they tell me something, or they tell my research staff something in an interview or a survey, and then we did nothing. And doing nothing is doing something. So we were the first adults. They know it's a psychology study, so they probably think we're clinicians or something, right? And so they might think that this risk behavior that they're doing or suicidal ideation is either condoned, it's expected, it's unpreventable, or adults are not somebody who talks to me about this. And so it really upset me. So I did do a lot of research on adolescents' attitudes, and many of them they were very interesting. They really had very specific areas in which suicide, obviously, very dangerous drug use, some of them bullying, they wanted disclosures. Even if you promise confidentiality, they wanted disclosures, obviously child abuse. But what's interesting is, and this is, they varied in terms of who they wanted to be told. They hate school counselors because they think school counselors are gossipers. And of course, now we don't even have school counselors. There's not enough money in school. So that's, you don't even ask that question anymore. But, so some of them wanted their parents to know, but they all preferred an outside referral. And it was very interesting, because we did all different racial ethnic groups. And it was the Asian students who particularly wanted an outside referral, not to tell their parents. And I think in the area that I was doing, a lot of their parents were immigrant parents. And it wasn't that their parents didn't love them or take care, but their parents didn't have the resources. They wouldn't know how to help them because they were new in the country, did not speak the language. And so these are things that are, really important that we have to consider when we're working with different populations. Okay, so we all know about confidentiality. It protects participant privacy, social, economic, and emotional harms. It encourages future participation. It encourages participant responsibility, avoids feelings of betrayal. It avoids us acting on false or inaccurate data. It could be, or anybody could be bragging or not telling us something. And it also protects against undue investigated decisional authority. Who are we to make these decisions? So you all know all these confidentiality protections. John just gave a great description of one of them. Anonymity is one of them, de-identification, subject coding, even in qualitative, certificate of confidentiality, and then field investigators who are not mandated reporters. Okay, so one of the things you really have to think about is you may not be a mandated reporter, but the people in the setting that you're in may be mandated reporters. So you have to understand that that then subjects you to mandated reporting in your state for whatever the state reporting laws are. So the certificate of confidentiality protects investigators from subpoena of data. It does not protect against subpoena of child abuse. The language allows NIH to have access to data. So what's very interesting, if you really tell somebody about the language in the certificate of confidentiality, somebody did a study where they had the language of the certificate and not the language of the certificate, just that we don't have to, respond to a subpoena. And a large percentage, like John found, a large percentage said, I don't want the government looking at my data, because the government has access to all the data. So it's very interesting, talk about if you really inform people. I mean, I've never had the government come and look at my data. I don't know if anybody else has, but okay. But it does not prevent the investigator from disclosing confidential information. The subpoena is a protection to the investigator, not the participant. So if you want to disclose information, you can disclose it. And obviously you have to think about what your confidentiality protections and whether or not what you told them you might do and what you are deciding you are going to disclose irrespective, because you didn't expect this to happen. And now you're in this situation. The APA ethics code, that I helped develop, American Psychological Association, you're allowed to disclose if somebody's in harm, if there's harm to someone else, there's harm to you. So many of the practice guidelines, and we don't have any in research, so that's a problem. But many, but if we generalize or do transferability to guidelines for practitioners, it's certainly ethical to do this, and sometimes you have to. Okay, so what are the challenges, right? When might we be in this situation? Like I said, we're finding out that someone's buying or stealing drugs. I don't think we would tell in this situation, but what about they're using a child to buy or sell drugs? I can't remember, what is the woman's name, Lloyd, it was at NRC, NCR. Did a lot of, can't remember. Anyhow, she would go into these homes and witness these. She wrote a great chapter, I think from one of my books, but I can't remember. She would go into the home of people who were drug users. Basically their kids would have sex with the drug users to get the drugs, and also the parents would think that would make the kids safe, and because they'd have a protector. And she grappled with, what is my responsibility here? I'm not a licensed professional. Is my research more important than protecting this kid? Am I protecting this kid if I report? So these are some of the dilemmas that, people who do, ethnographic research in these areas face. She decided not to, but she was very, very troubled about it. She also had somebody, oh God, this was really hard. God, I can't remember her name. Starts with a D, I think, but probably not. But
I think Alana did something similar.
no. This is where you were at NCR, NRC,
NDRI.
NDRI. Yeah.
It was Eloise.
Eloise Dunlap. Yes, that's who it was. She also, one of her participants told her that they were going to go kill somebody. And she didn't know what to do about that. But in that case, she actually acted on that. And I can't remember how, but she didn't tell the police, but she did tell that person that he was in danger. Anyhow. But I don't think mentioned the name, because then they'd come kill her, which was one of her concerns. And that's what I mean about the gang violence. And there can also be interpersonal violence, not just for what happens if you're talking to somebody and they're telling you about their beaten up and they're afraid to go back to the place or whatever. Are we going to call to help them get a placement somewhere, things like that, right? Which may give them their permission, but yeah.
I have a question, because this came up in our studies, was that if there was a mandated reporter on the team, or the PI was a mandated reporter, it did have an impact on what the lay staff,
Yes,
because even though they weren't mandated.
exactly.
reporters, the PI was.
Absolutely.
So they did have to act on those things. So I just wanted to clarify that.
Absolutely.
Um,
And that has to be part of the protocol. And that's what I meant. Sometimes we work in a hospital or we work in a school. And the school is a mandated reporter. The hospital is a mandated reporter. We are not, although I am licensed. But
A lot of universities have made researchers mandated reporters.
yeah.
Except Penn, I was.
I've made my
That-
staff, it's always because I'm a mandated reporter.
Right.
They're all
It's
mandated to
because-
report to me,
Right.
because I'm gonna, and that's what you're talking about. So
Right, that's
what
what
if,
I'm talking.
what if your data analyst happens?
absolutely, that's what I'm saying.
And they see the data, right? Then suddenly they're violating someone's confidentiality that was promised.
If you're out in the field and you're not licensed, then you're not a mandated reporter necessarily. If you're all by yourself, like, I don't know, what the situation is, but yes, that's the important part. You have to understand the context you're in, the people that you're working with. If they are licensed reporters, that then it's not legal that in some places, maybe it may not even be legal that it transfers to you, but it will transfer to you, especially if, like Lloyd is a clinical psychologist, so it transfers to him. But it's respect for the school situation. I'm sorry, what did you want to say, Bennett?
I wanted to ask, does this come into like the role people are in the situation? Information that would be mandated.
Yes.
But they're not social.
Yes, but if they're licensed, right, it depends on what their role is. It depends, if they're hired as a research assistant and not as a social worker, then they're not a mandated reporter at that time, but they have to know that, I mean, you have to make that clear.
No, we have, but that was.
But they can't be doing clinical inquiry. But why are you hiring them?
It's for its
Jobs?
No, I'm sorry, I didn't mean that. What
I didn't want to work. Listen,
what I meant was, do they work as social workers in the institution?
No.
Okay, I'm sorry, that's what I meant. I wasn't.
I don't Why in the world would you hire them?
I really, I actually, I 100% don't know. But I don't know, like, can you turn on that? I was under the
Well,
impression.
let me tell you, what's interesting, okay, I don't know either. I am generalizing for
I don't know.
this. When we admit somebody into our clinical program, who's going to be trained as a clinical psychologist, and they are licensed social worker, they are not allowed to do anything that has to do anything with their social work. They're not allowed to put anything on a card. They're not allowed to sign anything as a licensed social worker. They cannot, that is because as a trainee in a clinical psychology program, they're not allowed to do anything. So that's the only thing that I'm saying, that they're, that, I don't know why, if they're just hired to,
I mean, I don't know if because
don't
I've
know.
always been in like schools of medicine and like really it's a blanket, all of us are.
Yeah, it's a blank, that was for us too.
So I don't know, like, cause that's the.
I don't know.
understanding I
So-
come from.
yes, we all don't know,
So check.
check. Then the issue here is check.
I'm only asking because it's come up, we've had these conversations like in our research team, like they're, our they say, what if someone tells me they're gonna, they're having suicidal ideation during one of their survey interviews? And we have a protocol for that, and we say, follow the protocol.
Yeah, but we're not mandated reporters, just have to report child abuse and maybe age abuse. That's the only thing.
No harm. No.
But they-
You would follow a protocol. That's not a mandated reporting.
New York State, I have.
Check with me, that's any questions that would get answered.
That's still not a mandated reported thing, though. If
Yeah,
you're-
But I mean, in general, they're like, I'm like, it'll never come up, this should never come up in our interviews, ever. If it does, there's a problem.
Sometimes people just talk.
Yeah,
I just was curious, that's all.
Exactly.
Exactly.
That's the thing.
Comes up a lot no matter what you're.
You know,
interviewing.
point.
Yeah.
Yeah.
I think I have no idea, and I'm glad your site is talking about it, right? But I really think if they're simply acting in the role, and it's, if child abuse would come up, or reporting, elder abuse and whatever else is New York State law, and I think those are basically the two. And there's another one, but I can't remember what it is. Then it's something to really think about, and maybe not use the social workers, think about that. Or have something that you have to think about, should I be reporting that? I mean, if you find out about child abuse, I think it's something you really have to think about, but you don't do that, yeah.
I mean, I would also say that, being a mandated reporter in some ways makes it easy. And even if you're not a mandated, the whole thing of mandated reporting is it takes the decision out of your hands and out of your staff's hands who are doing the interview. And even if you're not mandated, it might be worth acting like you're mandated.
That's exactly it.
Yeah.
Exactly.
It's much cleaner.
But you need to know, well, anyhow, I'll go through how you figure that out, but that's good. No, it's interesting because we're dealing with, and like Brenda said, the issue is to check. And my concern, because I work in the schools, was that even though I'm not licensed, if I find out a student is doing something that they are required to report, and now it's guns. I mean, schools are required to report a lot of things right now, right? And so I'm within their context. And even though I'm not required, I'm betraying them in some sense because they have a responsibility to that kid. What?
Not that I was fact checking you in real time, but I did. And yes, I was looking at the New York State and it says like a physician in his role, they give an example of child abuse. As a physician, he reports if he's got or she is driving home and see it, they are not mandated to report.
That's what you just said.
I know, but I
Yay.
fact-checked her.
You doubted me, Brenda. Oh, no.
But very-
Oh, no. There goes our relationship.
That's just like joining an HIV study and then being accused, I don't trust my partner.
Right, exactly.
I mean,
Okay.
the one thing about mandated reporting though, is that it's not always in the best interest of the participant. Like, the case where a 15-year-old is having sex with an 18-year-old that might trigger mandated reporting in certain states based on age of consent.
Totally don't care.
If they feel like that's a consensual relationship, it's not in the best interest of your participant to report that. So I don't know that defaulting to mandated reporting is always, it's certainly easier on the PI's conscience, I guess, but it maybe isn't in
You
the.
have to take them through the way you figure this out, because that's exactly right. But if I hear such child abuse, I'm sorry, to me, that's a no-brainer. But you gotta do it in an appropriate way.
I know I walked in like way in the middle of this.
But you don't
conversation,
know if they're really abused, yes.
But I've also had, I have had this come up on my teams and I have people who are mandated reporters in their day jobs and it causes conflict for them
Right,
to think about not reporting. I've had
Exactly.
people say, I will follow my professional guidance no matter what you tell me to do.
that's right. Well, then, too bad for them. That you shouldn't, they can't work for you.
Then we had that conversation,
Yeah.
but they were not willing to, they were gonna follow their professional code of ethics
Right.
above anything
So
else.
they didn't understand their job.
Which was no longer their job.
It was no longer their job. But yes, they have, and that's what I meant with the social workers. They like it.
Talking about that.
It's a tough thing. Being a parent is tough too when you're working with kids, like you have this feeling you want to do something. Okay, I'm totally supposed to where we are, but let's keep going. Okay, so other confidentiality challenges, like I said, using or sharing toxic drugs with others. A victim of child abuse, knowing that somebody's abusing a child. Somebody tells you they're sexually abusing a child. Once again, you may not know this, and that's why I have a series of things you have to ask yourself. Unaware partners known to be HIV positive, like the case I was talking about before. Acquiring a gun with violent or suicidal intent. If you're a clinician now, you're required to report that into a database, and that person's gun gets taken away. Sexual behavior with a minor. I mean, these are just all horrible things that you hear about. Okay, so there are also confidentiality risks with recruitment, some of which we've already talked about. Just if they come to a treatment site, they may be identified. This is especially true like in some of the international settings, right, where you're doing HIV work with women and, you want them to be able to consent, and their husbands or their partners or their brother, whatever, is required to consent. How do you protect them? Is there a back door? Do you just say it's a health study? Do you not say it's an HIV study? All those kinds of things. Interviews in the community can be a risk, right? Like we saw in that video I showed, right? You're approaching people. It's I've done studies on moral distress with field workers who work in HIV drug use. And as one of the women was saying, they all know me, I'm the HIV lady. So, we have to be thinking about how if people know what you do, they also know whoever you're talking to may be at risk for HIV, drug use, or whatever it is you're talking about. Interviews with informants can also be dangerous because you may be providing confidential information and don't even know it as you're interviewing. There's also disclosure risks if you're working with unique populations. Obviously, with American Indian, Alaska Native particular tribes, that's been a big issue in terms of you're working with them. You may not mention their name, but they can be identified. Or you're working with people that have a unique medical disorder in a particular geographic area who can be identified. And of course, now we know with the genetic research that what remarkers and a couple of demographic information and you can be identified. So we have a lot of collateral resources. If you're talking to family members, you could do harm to longstanding relationships depending on what your questions are, right? There may be legal risks for family members if you're informing them about something, or you may be talking to a male partner, telling them something risking family violence, right? Which is some of the things we've been talking about in terms of HIV and things like that. And then one of our challenges is if you're doing that and there's conflicting sources, how do you decide if you think you have a disclosure obligation when a fabrication has occurred? Now, in clinical, in state law, let's say New York State, which is the only one I'm familiar with for child abuse, you have to have only the suspicion. Now, nobody really knows what the suspicion means, but that's it's a vague term, and so where that lies, but I think it says how we're dealing with some of these disclosure issues. Okay, reasons to disclose: mandatory reporting laws. Participants who are suicidal and may not know they need help or are not in treatment. Others who may be in harm's way, like the Tara stuff I just told you about. And thinking about, as I was talking about my feelings, the iatrogenic effects of failure to disclose, especially with marginalized and needy, populations like children or adults with their disabilities. Okay, so this raises the scientist-citizen dilemma. Do scientists have a citizen's obligation to help those they know are in jeopardy? Or does our investigator role supersede such citizen obligations because we're producing data that is supposedly going to advance the welfare of everybody once our data gets out there? Do scientists with expertise in problems of suicidality, child abuse, violence, I will add HIV, drug abuse, have special obligations to help those they know are in jeopardy? So again, this is a dilemma, so there's no right answer. But I think it should haunt us. So that's just my opinion. Okay, so what are the steps for determining confidential and disclosure practices? Because as John was saying, disclosure can just be as dangerous as maintaining confidentiality. So one is, so these are the 4 stages: investigation, deliberation and formulation, implementation, communication, evaluation, modification. I'm going through them. Investigation. You're doing a study with people who use drugs and people who are at risk for living with HIV. Okay, so you already know, and you may know that they do not have homes. You may know that they're marginalized. You may know that they're in gangs. I mean, this is the nature of your study. It's your inclusion criteria. So you already know that there's a certain level of risk that is involved in these populations. So you should know beforehand, what are your federal, state, and local reporting laws? Do you know some states' reporting laws are for citizens, which means you are a mandated reporter. So you really have to know the state. Okay. Identify the risks that may be revealed during the course of research. We're researchers, we should know what we're studying and what the potential risks that are going to be disclosed to us are. Evaluate the validity of the risk assessments. Most of us are not clinicians, and even if we are, we're not doing a diagnostic battery that may be sufficient to evaluate the risks that we're worried about. So we really need, I'm not saying we should have a clinical diagnostic, but if we're going to report something, we need to think about how valid, is a survey instrument that asks, how many times do you think about suicide this week? I mean, that's a really standard one that people who do non-intervention research use. What are you supposed to do with that? I'm not gonna tell you, no. You can ask. Yeah, I think as John, didn't talk about, but you really need to have a suicide protocol. You're get an answer like that. Doesn't mean you're gonna report it, but you need to have some kind of a protocol. Okay, and you need, if you think that this horrible thing is going to happen, even though it's very slight, you need to know what is gonna be a policy for referring or reporting. What are my criterion level? If I'm doing a risk assessment, is there a, validated measure of suicidality that I actually, other people have known to be a great risk? Okay. And then if you're if you think you may have to refer somebody or report, you have to know what are the available services in there so that you can do it. So the next is deliberation and formulation. So identify stakeholders who can help you, your community advisory boards, right? They can help you. I remember years ago, this was, when I was doing some of these studies, a lot of the community, this was early HIV, but a lot of the community members felt that anybody who had HIV was doing unprotected sex was a danger to the community. Therefore, should be part of a disclosure to partners if you knew who they were, which is very interesting, right? But that was the very early days. Okay, then consult with the stakeholders of potential harm, like child abuse reporting, etc. Speak with prospective participants about child and parent expectations, if you're working with that. But one of the things we found when we were interviewing and many different studies is this sentence that I may have to report you if there's harm to yourself or others, or has no meaning to anybody. They have no idea what we're talking about. So we have to be specific. These are the things I have to disclose. These are the things I may disclose, and be transparent with people. Just like John, actually John's questions are very transparent in terms of the potential risk, but this is another transparency that's really important. Also, you have to consider the threats to experimental validity and recruitment, and that's a real concern. You have to weigh those things so that if you are going to have to disclose a range of issues, then, some people don't take out the child abuse question from surveys that they do or from interviews they do, just so they don't have to report it, so that they can have, because if drop out. But in my opinion, you can use that data for people that if you had to disclose, you have data about the people you've had to disclose to. And so that's also valid information. And then obviously develop a confidentiality and disclosure policy. Then you have to implement and communicate. So establish the appropriate relationships with referrals resources, because if something occurs and you have to do something, you need to already have a relationship. Train the research staff to follow the policy, whatever it might be. Explain the policy to prospective, as I said, and guardians, because I do that kind of work. And whenever feasible, inform a participant when a disclosure has to be made. Okay, so that they are prepared. Lisa Lee's going to come and talk about public health ethics. But in public health ethics, you're supposed to do the least restrictive, kind of interventions possible. It should be the same thing with this. If you feel somebody's in danger, it should be the least restrictive, least autonomy risking. So if in fact a referral is appropriate, then that's what you want to do. You want to make the referral. Sometimes, you might have staff that bring people over to a place that needs a referral. Okay, then the last stage is to evaluate and modify. So you want to monitor the impact of the policy. on the participant welfare, did you harm the participant if a disclosure was made? Were you totally wrong in how you even assessed what the risk was? Or did the opposite happen? Did you not disclose and then something terrible happened? So this is monitoring your policy. How did it affect the study integrity? What does that mean about the way you're doing the study? How is it going to affect recruitment in the future and community attitudes? And based upon the above, alter the policy appropriate. So also think about your field researchers, because, you know, in drug abuse research in particular, a lot of times we send out people who were former substance users because they have, you know, confidence in the population. So, you know, and that's a great benefit to us, right? You know, because of their knowledge and their ability to relate. But at the same time, there are risks. They can have community alienation. There's multiple relationships that happen. There's deception. And so we also have to make sure that they are also not, what we found with our community research workers and all the studies I've done on that is, you know, sometimes they start doing counseling, they start doing this, they start giving money away. Sometimes people knock on their doors and they have to give money, or, you know, or they're considered medical experts. And, you know, so you really have to be not only training them what not to do, but listening to them about the challenges they face, because maybe we need to build that something in the protocol to protect them and also to learn from their wisdom. So that's really important. Okay, so I don't know what these points are, but this is my summary. Use data-driven confidential and disclosure decisions. Train your research team. Self-reflect on our own fears about our research, fears about helping people. As you can see, I get very concerned about kids. Understand the scientist-citizen dilemma, that is a dilemma. Which one should we prioritize? That's what makes it a dilemma. And, you know, that we're all striving to do our research well.